Good afternoon, everyone, and welcome to Mrftt Hiv Sti Echo. This is our 92nd, heading towards the century session. And today's session is, I think, of tremendous interest both to providers and the person living with HIV. The issue of long-term HIV survivorship and aging with HIV is a flourishing field of research that, if you think back 15, 20 years ago, when we were focused more on getting the response going in the country and getting people on meds, we are now at a point where we're transitioning. So many people have been on meds for so long and are doing so well, but they are entering their fifth and sixth decade of life. And we are now beginning to understand, as a scientific community and a community of caregivers, what their special needs are and what their special requirements are, both physically, medically, and emotionally and psychologically. So we are tremendously privileged to have with us Dr. Samuel Jackson. Dr. Jackson is the acting assistant professor in the Department of Psychiatry and Behavioral Sciences at the University of Washington. It's his first visit with us, so it's a warm, truly welcome. And Dr. Jackson, the floor is over to you.
Thank you, and it's a pleasure to be here. So I'm going to talk a little today just about some of the psychological effects of what we understand of the psychological effects of long-term HIV survivorship and aging, with a focus more on kind of the MSM population, since there's a lot more research on that. So let's get started. Oops. All right. So as we know, the HIV population is aging quite rapidly. So this is our global HIV population. If we're looking at projection numbers, in 2020, the under 50 population was approximately 53%, where the over 50 population was 47%. However, at the end of, by the beginning of the next decade, in 2030, we're projecting that the over 50 population of people with HIV will be 74%. So this is going to be quite a geriatric population. So a lot of geriatric medical and psychological issues are really pertinent when we think about this. One thing that I think about as a psychiatrist that works in a medical field is that we know that the number of medical comorbidities increase as our population ages. So this was a projection done of non-communicable diseases and the burden of healthcare costs amongst HIV positive persons, specifically in Italy and the United States. This graph right here is for the United States. But if we look at 2015, having 0 additional non-communicable diseases is 29%, and we slowly kind of increase up in that time frame. However, when we project out to 2035, we've actually had to add a whole second category because we are continuing to add additional non-communicable diseases. These are hypertension, dyslipidemia, chronic kidney diseases, diabetes, strokes, heart attacks, and non-AIDS related malignancies. So by 2035, at least in the United States, but this actually holds true in their projection for Italy as well, almost half of folks will have 3 or more non-communicable diseases. So lots and lots of medical complexity is going to be added to our patient population. When we think about mental health, though, in our older population of people with HIV, we know that HIV positive patients over the age of 50 do have higher rates of depression and overall poor cognitive functioning than the general population. One of the most common side effects of HIV positive, or that HIV positive patients have and complain about, even when virally suppressed, is fatigue. And so fatigue oftentimes leads to poor cognitive functioning. And then as we age, that rates of fatigue, that cognitive functioning, it worsens, going higher. Rates of depression increase in older HIV individuals. This is actually counter to the general population. As we age, HIV negative individuals tend to actually decrease in overall rates of depression. So this is something that is we need to be addressing as we get more and more folks getting older. People with HIV are also likely to be more likely to be socially isolated compared to their HIV negative peers, as well as younger persons with HIV. And additionally, older women with HIV and our BIPOC individuals with HIV are especially vulnerable to social isolation. One of the things that we all know with the COVID pandemic was that social isolation increased for many, many people across the world, but it significantly impacted the older men who have sex with men population during that time period as well. So when I think about all of these additional mental health stressors, when I think about what's kind of going on, I always like to think about kind of where some of this stuff is coming from. And so this was a really important study that Elon Myers, who was out of Columbia at the time, did in the early 1990s, is really trying to understand why why folks with HIV, especially in this case, men who have sex with men, had poor mental health outcomes. And so not just having the disease itself, because that couldn't explain everything. And so he came up with this ecological model looking at these distal and proximal stressors, such as prejudice events, discrimination, and violence, as well as our own internal senses of expectations of rejection, having to conceal identity, our own internalized homophobia and transphobia. And then this was also kind of mixed in with additional minority stressors or stressors related to race and ethnicity, gender, immigration status. All of these kind of contribute to having positive or negative outcomes. And in this case, negative outcomes. But he also was very interested in understanding resiliency and how we could buffer or have stress buffering of this to improve our mental health outcomes, to be able to kind of overcome these distal and proximal stressors. And so I practice what I view as positive psychiatry. I really want to know where my patients are coming from. I really want to understand what my patients have as sources of strength to overcome the problems that they're facing. And one thing that I really like is looking at things through the eye of resiliency. And so resiliency is probably one of the most well-researched phenomena that has poor definitions. There's so many definitions of resiliency, it's really hard to kind of classify. But I really like this model from Richardson out of the University of Utah, where he looks at the meta theory of resiliency and thinking about everyone is kind of floating around in their own kind of biopsychospiritual homeostasis. So we're all doing the best we can. We're kind of at our baseline. We have protective factors that are buoying us against the kind of general stressors of life and our adversity and things like that. And then something comes along and has a disruption. And that disruption event sends us in a little bit of a free fall. We have distress, we have depression, anxiety, as a result of that disruption event. And then the disruption event disappears or goes away at some point in time. And in that process, we then have to kind of reintegrate to a new place. And I actually call this the stoplight model, mainly because it I did this as more of a stoplight model. It was in black and white, but I kind of like the idea of looking at it from like the stoplight where you can have dysfunctional reintegration. So that's having you have the event and then everything is just terrible afterwards. You end up living on the streets, you end up having a substance use problem, financial ruin, things like that happening. You also just have reintegration with loss, where you're not doing as well as you could, but you're not totally dysfunctional. Um, Reintegration to baseline is actually the most common. Most people after a disruption event will kind of reintegrate to baseline, kind of going back to where they used to be, where they were, what their level of functioning was. But some people end up having resilient reintegration, or what we'll also call post-traumatic growth. Something inside of them is sparked to grow and develop from the disruption event, and really kind of gives meaning to their life, or gives a new meaning to life. And this isn't just, these are not all, like, this is not an all or nothing. People can have resilient reintegration in one area of their life, but still have reintegration to loss. But the majority of people are going to be in the green with this reintegration. So I think about this because I also work in cancer and psycho-oncology, and one of the things that's very common amongst cancer survivors is this idea of, I would never wish cancer on someone, but I'm so happy that I got cancer and I survived because I have a newfound appreciation for life, or I've figured out something about myself and I can give to other people. And it's that post-traumatic growth of making something out of the negative that I'm really interested in as a practitioner of positive psychiatry. So when we think about this model, and we think about this model in the context of HIV and AIDS, um, specifically, I look at this in our aging cohort as a generational trauma event. So we have our folks kind of floating around at their biopsycho spiritual homeostasis, and then the AIDS epidemic and pandemic hits. And so this, to me, is a really important thing to understand for folks living with HIV who are 50 and older, because the beginning of the pandemic was a huge, huge disruption event for their lives. So this is a picture of the San Francisco Gay Men's Chorus in 1993. Everyone in a black suit with their back turned towards the camera is someone who passed, is a representation of someone who passed away in the chorus as a proportion of the whole, whereas everyone in the white facing the camera is the person who is still there. We lost so many people in this generation that it becomes this huge generational trauma event that this cohort all faces together. So looking at this in kind of the framework of the generational trauma, if you look at United States data, you look at the data from Trinidad and Tobago, you see deaths from HIV spiking. In the United States, it's in the early to mid 90s. In Trinidad and Tobago, it finally spikes the latest in 2000. There's so many people that are lost in this disease. The survivors then kind of go forward with a lot of survivor's guilt and questions, and not knowing why they survived, what was made them different, and everything like that. So kind of looking at this, in 1996 in the United States, 1 in 9 gay men was HIV positive. 1 in 15 had died from the disease. So life before ART, life in this era was a provisional existence. And this comes from Viktor Frankl's Man's Search for Meaning, when he was really thinking about what it was to be in the concentration camp, but he also kind of applied that to other parts of our lives, including living with a terminal illness and living with this unknown. And so he says, a man who could not see the end of his provisional existence was not able to aim at an ultimate goal in life. He ceased living for the future, in contrast to a man in a normal life. Therefore, the whole structure of his inner life had changed. And one of my patients told me this as a kind of a quote, as a personal kind of quote that I really think sums up the provisional existence for folks in this setting. If you don't know when you're going to die, what's the point in saving money for the future or making plans? You just live for the moment and you try to cope. There's no future, there's no hope. You're just stuck. And so you are watching people dying all around you, and you're just waiting for the next shoe to drop, and you don't know what's going to happen. And then as we start getting more of our antiretrovirals, we get more dissemination across the world with this, and we're able to get the pandemic more under control, and it's no longer a death sentence. You're left with this population who saw many of their friends die around them, who are now the only survivor, and it's decimated their friend group. They're oftentimes isolated from their family, and they don't know really what to do or where to go from here. So this was a quote from a qualitative study of AIDS survivors in 1998. And the idea is the next problem is not going to be coping with death, but rather coping with the rest of our lives. The fallout of not saving money, the fallout of the early ART regimens and the physical health effects that those left on them, or the physical effects of reaching AIDS and having all the opportunistic infections before we were able to get things under control. So the multi-center AIDS cohort study in 2013, 49% of men who had sex with men agreed that with the statement, because of the HIV epidemic, I never thought I would live as long as I have. 27% had reported losing more than 10 people close to them from AIDS, and 35% report that they still grieve for those that they lost. 7% deeply grieve, and 3% grieve every single day. So this is a huge event. This is generational trauma for folks. And as healthcare providers, especially those of us that have trained in the ART era, it becomes a little bit hard for us to understand that and seeing that trauma. So this was a really good quote from a study in Sweden. In the early days, healthcare staff asked us about our well-being, and now they're only responding to our numbers looking fine. So everything must be okay. We feel like we're forgotten, and our healthcare staff don't ask us about what we see or what we're experiencing. I think back to a conversation I had in medical school with someone, and it was someone. It was I found it difficult to hear at the time, and the longer I've been doing this, the more just out of touch this was. One of my colleagues was kind of asking folks, he's like, "What would you rather have? Would you rather have diabetes, or would you rather have HIV?" And I think a lot of people answered that they would rather have HIV because it's not that big a deal. You just take your medication, and you don't have to worry too much about it. Whereas diabetes, you progress, you get neuropathy, and I don't think that everyone has that same kind of callousness, but those of us who've trained and didn't see the peak of the epidemic do have this kind of feeling that it's a chronic disease. And so this is something that I really try to think about in terms of my older folks with HIV, is the fact that this is not just a chronic disease. This was a huge, huge event for them in terms of losing so many people, and that there's so much trauma in that, and that we as healthcare providers owe it to them to recognize that trauma and to recognize that they may still be suffering even if they don't tell us. So as we are aging with HIV, what do we think when we think about the physical and the psychosocial and the systemic barriers to successful aging? Really, what we're thinking about are things like adverse mental health outcomes, this survivor's guilt, this PTSD, depression, substance use, social isolation. Our older HIV patients are quite often more socially isolated or have very fragile social networks. Their quality of life is oftentimes worse. They have adverse effects from the medications, from the effects of the disease, as well as just loneliness and shame, and that kind of still internalized homophobia or internalized transphobia. Then there's the stigma that's associated with being HIV, and stereotyping of folks who are HIV positive. We oftentimes think about this in terms of in the United States, especially the marginalization of people of color, and our BIPOC um, friends with HIV have lower socioeconomic status, and that marginalization is very, very traumatic for them in this way. You also just have physical aspects of aging, the greater comorbidities, increasing stress, increasing pill burden on you as you're taking more and more medications. So now it's not just the ART, now it's a blood pressure medicine, now it's a statin. We're adding things on in that chronic reminder of illness and aging. Like I said, fatigue is one of the most commonly reported side effects of HIV, and it's oftentimes reported as the most debilitating side effects. And then you have the appearance issues, the changes that occurred, the Kaposi sarcoma that the lipodystrophy, things like that as a reminder, and having that chronic poor quality of life just due to these changes. Um, but it's not all doom and gloom. Like I said, I'm a positive psychiatrist. So I like to think about this from that and resiliency. And this is a population. Yes, they are traumatized. Yes, they lived with this generational trauma. For them, but they have so much resiliency in this population. So many studies of older folks with HIV they report they have a fairly good quality of life. In a study of in London. So obviously this was in the United Kingdom as a major world city. So lots of ability to have connectivity, but 56% reported their quality of life as good or very good. It's not perfect. Obviously, we would want it to be higher than 56%, but that's still pretty good. So when we think about this, what are the resiliency factors that are really important in older folks with HIV? And spoiler alert on this one, this is actually the resiliency factors that are important in people with HIV as well as people without HIV. So this is actually just universal across the board. These are the resiliency factors that are most important in terms of healthy aging. So this is social connectivity, this feeling of mattering, this feeling of generativity, that you can give back, that your life meant something, that you had a purpose, the ability to self-manage and to maintain independence, that you're not disabled, that you're not having to live in a nursing home, that you have some sense of agency and control of your own life, and self-acceptance of who you are, that you have this internal pride in who you are, and that goes back together with mattering and the social connectivity. These are all the most important things. In study after study with resiliency, the number one factor in determining resiliency and determining healthy outcomes is social connectivity and combating isolation. And it's something that I push all the time on my patients, is how do we get you out of the house? How do we get you in a connected environment so that you have people your own age, your own friend group that you can be with, and especially considering that this population was so devastated by losses of friends that they potentially don't have the family connections because of homophobia. How do we get that social isolation under control and get that sense of connectivity? And when you have a sense of connectivity, what you oftentimes find is that mattering and self-acceptance and generativity will follow lockstep behind those, because you have that. We are social beings, so you will feel connected. You do feel like you matter and that you do have acceptance of yourself when you're around folks that care about you. And so this is, brings us to the idea of post-traumatic growth. So our resiliency factors, by looking at that, by increasing connectivity, by increasing those different domains of resiliency, we develop post-traumatic growth. And so what is that? That's the qualitative change in functioning and development, not simply a return to our baseline. And there are really 5 domains of post-traumatic growth. It's this increased appreciation for life in general. And that's kind of harking back to when I talked about my patients with cancer who are like, I'm so grateful that I had this because I now have a better appreciation of life. Like, life means something. I know how precious it is. There's also the development of closer, more meaningful interpersonal relationships. increased sense of personal strength or self-efficacy, this realization of new life possibilities, and the spiritual or existential growth that happens. And post-traumatic growth is a trait, not a state. So these are things that we can cultivate as providers, that we can cultivate as friends and family members and others, and that growth in one domain oftentimes spurs growth in other domains. So when we think about post-traumatic growth, and especially in HIV patients, it's really important because post-traumatic growth, these changes are associated with higher rates of ART adherence, lower alcohol consumption, and healthier dietary habits. So post-traumatic growth leads directly into physical health. And so if we cultivate this as, like I said, providers, as friends and family, we are actually helping people live longer and healthier lives. All right. And I know that was brief, and it was just kind of a 20,000 foot overview of um, um, some of the issues in HIV and aging, and as well as just my soapbox on resiliency and what we can do to foster post-traumatic growth.
Thank you, Dr. Jackson. That was such a thought-provoking presentation and so much good information there. I will leave the floor open because I feel that there are lots of questions. So I will not be selfish. I'll open the floor for anyone who has any questions. You can either unmute or raise your hand, or you can type in the chat box.
Hi, Dr. Jackson. Thank you so much for that. And so much of that actually really resonated with me. The fallout of not saving money, the fallout of not getting by and not being in control. But I wondered, as you looked at that traffic light model, we talked about movement one way, but I wondered if any kind of studies had been done to look at if there was a progression that might happen from one all the way down to the red, or if there's any kind of general pattern with going back and forth across the stoplights, as it were.
Yeah, so I think the big thing to think about is that the stoplight kind of is a little bit oversimplifying, because it almost makes it seem like this is a state, right? Resiliency and reintegration is an ongoing process. So people oftentimes do progress up and down on the stoplight. And the other kind of thing it's thinking about is it's really oversimplifying in terms of this one trauma for it. This is oftentimes folks are already at a lower kind of homeostasis than the general population would be. And so as they then progress into, they may have more ground to make up, so to speak. And so people will oftentimes kind of be in a bad place. They'll be in the red. And through support with friends, with family, with getting involved in community and healthcare, you can progress up. And certainly you could potentially have another trauma or disruption event, or mental illness is a chronic disease. You could have a relapse of your depression symptoms and kind of start going down. But the nice thing to know, the nice thing is folks who have experienced post-traumatic growth, people who have gotten into the green in at least one domain of their life, there's resiliency in preventing you from going quite as far down back into the stoplight. And so that's what's important to me, is how do we get you not just back to the light green, but to the dark green in at least one area of your life, because that resiliency then will buoy you when we know with these relapsing and remitting illnesses, with depression and substance use, that we don't lose you as far. Maybe we go down to the yellow instead of the red.
While other persons are composing their questions, Dr. Jackson, do you believe that, or is it your opinion? So for some of our long-term survivors who may have been living with HIV for 20 and 30 years, who may be entering that phase of their life where they're beginning to feel the isolation a bit more acutely, because yes, we have lost so many of their peers in the early part of the epidemic, and now they begin to lose more of the few peers that have left in the late parts of the response because of the non-communicable diseases and non-AIDS cancers and so forth. Is this something that we should think about creating specific programs for specific clinics for? In other words, treat them as a special population, the same way as you might treat pregnant with HIV or adolescents with HIV, because the concern would be that if, and that quote was very from the study that you quoted, whereby your bloods are fine, so you must be fine. And if you over-medicalize the response, then we miss everything else. Is this something that we need to think about as some of our long-term survivors, creating, if not a special program, it is a special approach within the existing program?
Yes, absolutely. I think that looking at this as, very much like we have specialized just geriatric settings where we know that folks are going to have different needs. I think by the same kind of token, we need these long-term survivors spaces. And it doesn't necessarily need to be in a medical setting, so to speak. It could be a community organization. It can be through churches, through things like that, where but you need to have that understanding and that knowledge that that's kind of what's happened to them and that they are especially vulnerable for that. When I think about this, there's a big cohorting effect of people who were diagnosed prior to ART. Those are diagnosed kind of within the early phases of ART, kind of are in like one cohort. And those that have come around later, now that we have very good regimens, single drug, things like Descovy and Truvada, there's a difference, and there's a big cognitive difference between the two of them because of the mindset, and because our younger folks, or the folks who have contracted it more recently, did not have that experience. There's a lot of problems with relating between the two groups, and so having that kind of dedicated space of support is, I think, really important. I also think it's really important to have that support to be identified, because I think they do, that cohort has a lot to teach our younger cohorts, and a lot who are have contracted it with only the past few years, and really understanding kind of the weight of this, and that this, understanding the privilege that these current regimens afford you.
All right. Another question for you. What? Kosa. Let's see. Silence. Go ahead.
All right. So I don't have a question per se, but it's really a comment. So I recognize with but a lot of what was discussed, for example, the fatigue, the social isolation, the anxiety, and so on, the uncertainty of the future, and all of these things. As someone living with HIV now for almost 40 years, I experience a lot of these. And what I keep hearing is that there is this real need for support. And, in my role, I meet with persons living with HIV who are really needing the support. As I said, it's not a question, it's just a statement. There is this real need for dedicated support. And the support has to start from diagnosis and ongoing. And I really appreciate, the post-traumatic growth, because for me, I personally experienced post-traumatic growth, because after finding out that I was HIV positive, I went about making a conscientious effort, to change my lifestyle. I mean, people look at me and they say, "But what do you do? Why are you still so looking good and healthy and stuff like that?" And it is because of my post-traumatic growth. But we really need the support. And I think, for persons living with HIV, there's still lacking a lot of that needed support. Yeah. Psychosocial support specifically.
Absolutely. And I, I think that where I would focus the most on if I was pulling purse strings is with the peer support, starting at that level. Folks who, like yourself, have had the post-traumatic growth, who are living with the illness, that that is where I think most of the improvements we're going to see are. I mean, you can hire all the psychiatrists in the world that you want, and you can give all the antidepressants in the world that you want, but if you don't have that support, they're not going to do anything. And so starting from the bottom up with the peer support, with those that have long-term survivors that are reaching out to other long-term survivors, that's where you're going to have the most benefit in terms of psychological outcomes.
Hi, just
Conrad?
kind of pivoting off of what Cyrus was saying, and I started writing once I heard Cyrus talking. I think a huge part rather, of the growth and acceptance that might come about for PLHIVs comes from increased knowledge, but also visibility and being able to see other persons like themselves saying that, hey, it's okay. And I think it's a lot easier in countries like the US and the UK because there is such a strive to have it in the forefront of the public that it's okay to be, not okay to be positive, but that you can live complete lives as a positive person. And I think as we think of us in the Caribbean and specifically in Trinidad and Tobago, I think that's one of the things that we lack, and that we lack that constant visibility of positive messages around being PLHIV to help foster that movement from the red up to green. And I think that might be why some persons might stay in a place of pain rather than being able to swim up to true resilience, because there are not as many positive role models that are just everywhere in the form of media and advertising and things of that nature. Yeah.
Absolutely. And I trained in the southern United States in Arkansas, which is a fairly high poverty area of the country. And there's the difference in terms of visibility and acceptance between Arkansas and Seattle, Washington is just mind-blowingly different in terms of just advertisements and just seeing it all around. And I know a lot of my patients, when I was in training, did carry that shame, did carry that because they couldn't tell anyone, that there was too much stigma around that. And if they had, other people around them, they had the visibility and the signals. I think there is a huge, even if you don't know someone, just seeing that it's okay has a huge subconscious effect on folks. So absolutely, visibility is 100% key.
Oh, this is Alana. Sorry, I was driving, so I couldn't do the raise hand protocol. But I wanted to say something that surprised me. I was expecting to hear during your presentation that everyone over 50 was prone to more depression, whether you're negative or positive, except that HIV positive individuals had an additional layer of trauma that they had to deal with and were more susceptible. But instead, you said that HIV negative persons over 50 were less prone to depression, and I was kind of surprised at that.
Yeah, it's really interesting. As as we age, depression new diagnoses of depression start falling off quite a bit. Depression, the incidence of depression really peaks in in the 20s, early 30s, and then as you go further and further along, you too tend to see people having less and less depression or new onsets of depression. But even still, going further, so folks with depression, as you age, oftentimes the depression gets better. You learn, you just have more life skills and more knowledge and more kind of coping skills that you've developed over time to buffer against those feelings of depression. There are certainly subpopulations of the HIV negative population that themselves that have higher rates of it, specifically cisgendered heterosexual males who have lost a spouse will have are especially vulnerable. But on the whole, it's a very really interesting phenomenon that, you know, geriatric depression is certainly a real thing. We do want to screen for it, but just on a population level, it is quite a bit lower.
Right. So does the increased rate of depression in HIV positive individuals have to do a lot with anything? I might be using the wrong medical or clinical term, but with something biological that, or is it more social?
That's really interesting. So we know that folks with HIV have higher rates of depression. We also know that people with HIV have higher rates of treatment-resistant depression, meaning it takes more to get their depression symptoms under control. And so I think that it's probably both a biological effect as well as a social effect. This idea that there is a chronic allostatic burden, even when you have the viral suppression, there's still that inflammation going on that's driving some of the rates of depression. And I think that this mirrors the data that we're seeing from the Reprieve study, where starting statins lowers all-cause mortality. I think that very similar kind of biological effect is driving things like depression, because you can't explain the fatigue just from social stressors and things like that. And so I kind of view the neurocognitive effects of the viral being HIV positive, even when you're suppressed, as a driver of that. And then you just kind of add on to stigma and isolation and trauma, so that it kind of becomes a perfect storm of creating higher rates of depression.
Thanks. That makes a lot of sense.
Thank you, everyone, and thank you again, Dr. Jackson, for an excellent presentation and a lovely Q&A session afterwards.